Today we are covering lipids and lipase, and I guess that sort of the reason I put those two chapters together are not because the clinical problems we see when we see an elevated lipase are the same as the clinical problems we see with elevated triglycerides, but because it works so well together to talk about the physiology of fat absorption and fat processing in the body, and then go on to say, okay, well, what can we assay and what meaning does that have to clinically? So I thought we'd start with how fats are absorbed from the body or after ingestion. Is this a mystery to everybody else? I feel like I've read this a million times and I forget it every single time. What happens when you put a hamburger in your mouth? Or a veggie burger?
The first step is a bit of mechanical mastication. So they start to chew their food to break it down, which gives it a greater surface area for enzymes and bile acids and things to work on.
Amazing. Good. Yep. So it's kind of the beginning of the emulsification process of the breaking down into smaller parts process. Excellent. Is there anything in the saliva that will, other than the mechanical breaking down, is there any enzymes in the saliva that might contribute to breaking down of fats?
There's an amylase, I think, isn't there?
Lipase, actually.
Lipase.
Yeah.
But
yeah.
is there amylase as well?
I'm not sure, actually, because I was reading specifically about fats and amylase is the protein one.
Yeah, that's right.
The protein. Yeah. So there probably is, Jeff, but I don't know. Sorry. I knew at one point in my career. So yeah, there's a lingual lipase. And the reason I raise this is because we look at lipase on our blood test, right? We look at non-specific lipase. And there's lipases in so many places in the body. So there's lingual lipase as well as lipoprotein lipase and things like that we measure all in one when we measure lipase. So lingual lipase and the mechanical mastication process breaks down the fats into small pieces for us to be able to then get them into our stomach. What happens in the stomach? Well,
the stomach, there's acid.
Mm-hmm.
There's agitation.
Good. Yeah. Yeah.
What else have we got?
We get a little bit of bile coming up into the stomach every now and again, don't we? But the main mechanisms of the bile, let's talk about if we sort of say, okay, well, the fats are kind of been emulsified and been broken into smaller pieces in the stomach, and then they're moved into the intestines. And then what happens to them? What happens when fat hits the intestine?
Well, the intestine, the pancreatic enzymes come down.
Right. Which ones?
And the bile comes down. Well, the pancreatic proenzymes, which are then converted, and they've got the works in them pretty well, haven't they? They've got amylases, lipases.
Yeah.
And also the bicarbonate is there to neutralize the stomach acid.
Right. Excellent. Yeah. And that's a really important, I've spoken about this, but I'm really interested in the microbiome, so I talk about it all the time, but that acid tide that comes from the stomach is neutralized by bicarb. And if you don't get acid coming out of the stomach, so for example, if you're using Losec for whatever reason, might be very appropriately, you don't stimulate as much of the bicarb secretion and you don't get that acid-base population control of the bacteria. So often we see an increase in bacterial numbers in that proximal duodenum in animals that are on or that have higher gastric pH for whatever reason. So pancreatic enzymes, and the one I'm really interested in is lipase. So we've got fats have come through the stomach and they've landed in the intestine, and they're usually in like a fairly small kind of chain by this point. And they're broken into small pieces, which means that there's heaps of surface area for those digestive enzymes to work on. So the lipase is going to break the fats, dietary ingested fats, down into what?
Geez.
Kind of a tricky question.
It will break it into free fatty acids.
Good.
And glycerol to store or use as energy.
Excellent. Yeah. So essentially fats are a glycerol base with free fatty acids attached to it. So what those digestive enzymes do is break off the free fatty acids from the glycerol, which facilitates absorption. So if you've got lipophobic mucus coating on your intestinal wall, and you've got a free fatty acid sitting in the lumen, how does that fat get through that lipophobic layer and get absorbed by the enterocytes?
You have like, I don't know what the specific term is. Is it a lipoprotein that carries the triglycerides?
So you're exactly right, but that's actually what happens on the other side of the enterocyte. So what happens still in the lumen is that the bile acids form micelles. Have you heard of micelles? Remember that word? Yeah. MICELLES. This is one of those words that I've seen written and I'm not sure I've ever heard anybody say, so I might not be saying that. If anyone wants to correct me, I'm open. So they get packaged up kind of thing and bound and coated by the bile acids, which just mean that they can interact with a lipophobic surface, go through that mucus layer into the enterocyte, where then they get packaged up with lipoproteins to be then transported around the body. I found, I said this at the beginning, but I found fats just hard to get my head around because there's a lot of acronyms and there's a lot of stuff that they know about with humans is very important with humans. It's just completely irrelevant with dogs and cats. So what we kind of hear about fat health in humans is just not that relevant. But I found this really nice pit diagram in a paper, which I'll just share with you, which then describes once those micelles have been absorbed into the enterocyte, they get packaged up into a chylomicron. Can everyone see my screen? Great, excellent. So this is the blood vessel. Yeah. So they get packaged up into a little chylomicron. And then, so that's the combination of a lipoprotein and a triglyceride. And then this is another lipase that we see. So lipoprotein lipase is the enzyme that will separate the carrier from the fat and allow the fat, whether it's a cholesterol or triglyceride, to be deposited into whatever tissue or bloodstream or whatever it needs to be deposited into. So the chylomicrons release their triglycerides into tissue. The remnant goes back to the liver and then participates in forming these more advanced cholesterol and triglyceride carriers. Does anyone know those as VLDLs, LDLs, and HDLs? Does anyone have that in human health?
I think that's the biggest difference with humans and animals is that humans have the very low density lipoproteins, and they're the ones that are prone to oxidative damage, and they cause the cardiovascular effects that humans have, so like atherosclerosis and increased risk of heart attack and stroke.
Perfect.
But cats and dogs have high density lipoproteins, which don't seem to have those same like we don't really appreciate that in our veterinary animals, the like cardiovascular risks.
Yeah, good. So the VLDLs and LDLs, so the ones that are the LDLs, low density lipoproteins, their job is to take lipid away from the liver and deposit it in tissue. So dogs and cats don't have very many of these LDLs, and they actually have a deficiency in the lipase required to separate cholesterol from its carrier at a tissue level. They've only got that enzyme in the liver. So they don't need many of those carriers because they don't the cholesterol isn't being taken anywhere. Does that make sense? So LDLs take lipid to tissues, whereas the HDLs, which in humans they say the good cholesterol, take lipids from tissues back to the liver. So I just found this, like, whilst it's a little bit of a confusing diagram, it's absorbed and some of the triglycerides go straight to tissues from the chylomicrons. Chylomicron remnant then goes back in to form part of those larger carriers, which can be either VLDLs or HDLs, which forms in the liver and then comes out, picks up cholesterol and takes it back to the liver for processing. Do you like my diagram? I didn't do it. Yeah. Thanks, guys. I feel like, Helen, you maybe shouldn't be looking at that diagram while you're trying.
Oh, I've pulled over to meet Zane, so I'm fine.
Oh, good. Excellent. Excellent. Okay. So that's how lipid is kind of moved around the body. So if we've got a blood test result that shows a hypertriglyceridemia, why might that be? What are the different kind of categories of causes of hypertriglyceridemia?
Postprandial would be a big one. You have to have a fasted sample.
Perfect. How long? How long do they need to fast for?
I think at least 12 to 14 hours.
Yeah, good. Excellent. And it's really important, like often we get patients to come in with their like trazodone and preclinic drugs on board, and people give them in a spoonful of peanut butter. Just when you say fasted, make sure it's fasted. So postprandial, so that's kind of like an insignificant hypertriglyceridemia. What about cholesterol? Do we see postprandial hypercholesterolemia?
Ooh. I thought yes, to an extent, yes.
To an extent, yeah, but a little extent.
But a little, not as significant as triglyceridemia.
Yeah. And the ranges that we've got for cholesterol in dogs are quite broad. Dogs in particular are quite broad. So it's quite hard to tip, unless a dog's like sitting at the high end of normal, you shouldn't really get a high level of postprandial with cholesterol. So typically if you see a high cholesterol on a sample that's not fasted, it's probably significant and worth then repeating with a triglyceride as well. What if it's not just a like kind of postprandial, what other causes of hypertriglyceridemia are there?
Primary and secondary, so diseases will do it. Schnauzers will have primary.
Do you know this or did you study this?
No, some things are in my head.
Oh,
Random shit.
I think what stays in your head are the things that fall out of mine. I think we're in a combo.
I was completely blank when you were doing the pathophase because I just don't think about it like that.
Also, it's not relevant on a day-to-day basis. But, okay, so primary and secondary. So tell me about the primary hypertriglyceridemia.
That's all I know. Like primary is when you can't find a cause, but because obviously it's a diagnosis of exclusion, I would think.
Yeah. Do you know, clinically, who do you see with a primary hypertriglyceridemia?
Schnauzers.
Right. So that tells you that there's probably a what cause? Maybe
genetic then?
Yes, exactly. Yeah. So we see it in familial hypertriglyceridemia, and that happens in humans and dogs. And I should say hyperlipidaemia because there are familial hypertriglyceridemias, which is the Schnauzer one in particular, but most animals get a familial hypercholesterolemia rather than a triglyceridemia. Beagles also get triglycerides. Does anybody know any breeds that get a hypercholesterolemia?
Kind of like collies and shelties get it, or do they get?
Yeah, they do. Yeah. And these are the, like, particularly the shelties, these are the dogs that have the mucoceles.
Mucocele too, yeah.
Oh, schnauzers and shelties.
Yeah.
Interesting. So I'd be really interested to see for someone to do a study and test that the specific enzyme that's absent in most animals and prevents atherosclerosis and the like tissue deposits of cholesterol. Like to see if maybe these dogs with familial hypercholesterolemia have those enzymes or something. It would be interesting. So they're the primary hypertriglyceridemia or lipidemia is a diagnosis of exclusion. You have to rule out all of the secondary causes essentially to be able to make that diagnosis. But in like, you know, a young schnauzer with a normal, like, you know, normal T4 and everything, you can be pretty suspicious of it. And if there's no clinical signs, I think it's reasonable to skip chasing other endocrinopathies and stuff. What endocrinopathies do cause hypercholesterolemia?
Hypothyroidism is going to be more likely to cause hypercholesterolemia, and hyper A is more likely to cause hypertriglyceridemia.
Yeah, or both, actually. I think they get like hyperlipidemia in Cushing's. They get both. Another one?
Diabetes will do it.
Good. Yeah. Why?
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 Like breaking down fat because they can't glucose into cells.
Yeah. Increased lipase activity because they've got no energy source other than their fats and some proteins. Excellent. What other diseases do we see hypercholesterolemia in?
Nephrotic syndrome, but that's a syndrome. Like you have to have the things in.
Good. Yeah, excellent. What about how is cholesterol excreted?
In the feces, isn't it?
Yes, good. Where does it come via to get into the bowel again?
Bile acids.
Good. So what diseases might you see which might limit the ability to excrete cholesterol?
Would IBD be then one? Because your ileal, like the enterohepatic circulation would be affected.
I reckon we'd get decreased resorption of the bile acids, but not actually a hypercholesterolemia. What about in the biliary system itself?
Cholestasis.
Cholestasis, exactly. Anything that causes a cholestatic pattern, so whether that's intrahepatic, so if you've got like a glycogen storage from Cushing's and they've got hepatocellular swelling associated with that, you've got intrahepatic cholestasis, you're going to get high cholesterol. It's one of the contributing factors to high cholesterol in Cushing's. Any disease of the gallbladder, which limits gallbladder contraction and excretion of bile, and any disease of the bile duct or next door to the bile duct. What's the
pancreas?
Most common cause of extrahepatic biliary obstruction is pancreatitis. So that's another one. And then there's one other. Tell me about hypertriglyceridemia and pancreatitis.
Is there also an element of like auto-digestion of the fats that's causing the elevated triglycerides?
Yeah, exactly. So we've got increased lipase activity, don't we?
Yeah.
So not necessarily increased lipase on our blood tests, but increased lipase activity when we've got pancreatitis. Why is a hypertriglyceridemia important? Why do we care?
Because it can cause like secondary consequences, even if it's not causing the same cardiovascular consequences like humans get. Like you can get little lipid emboli in your kidneys and get renal damage. And you can get it's like part of the mechanism of pancreatitis. You can get like impeded circulation through your little capillaries and ischemic damage on a capillary level, which like maybe why contribute to pancreatitis in them. And it thickens bile, so it makes mucoceles, and then you could get like a mucocele that ruptures or like a cholecystitis and affect the patient that way.
Yeah, excellent. And I think you've covered the pathophysiology really well. So essentially we get a hyperviscosity if you've got increased lipid in circulation all the time. So those tiny little capillaries are the ones that are affected. Where do we see tiny capillaries? Kidneys?
The eyes.
Eyes, very good. What diseases do we see in the eyes with hyperlipidemia?
Oh, you get the lipid deposits in the cornea.
Yes.
Whatever that's called.
Cornea, yeah. And don't they also sometimes get their like anterior chamber full of
nucleus?
Yeah.
Yeah, you can get like the whole anterior chamber. I actually recently had an interesting case, which was a 2-year-old female spayed ragdoll who came in on a Sunday morning with both her eyes completely white like that, like completely white.
Oh, White
And
Walker.
and she had a fasting triglyceride of 30.
Oh,
And
wow.
it's completely resolved with diet. Just I put her on she's on Purina HA and it's completely resolved. Her eyes are normal now.
How weird.
So weird. I was like, what
That's
the hell
weird.
is going on with your eyes?
I'm
Yeah,
so glad I didn't see that.
it's weird.
A nightmare.
But, yeah. I should have said that actually. We were talking about breeds that are predisposed to familial hyperlipidemias. Burmese are one. They get a hypercholesterolemia, and they often have ocular manifestations of that. Where else do we have tiny little capillaries?
In the brain.
Brain, good. So we get increased incidence of cognitive dysfunction in dogs with hyperlipidemia, earlier onset, faster progression, increased incidence of seizures. And in certain breeds with certain underlying conditions, we actually do see atherosclerosis. So it's documented in golden retrievers, and it's not clear whether those golden retrievers were on the way to developing hypothyroidism or not. So because they're overrepresented with hypothyroidism, there was like some talk in the paper about like maybe these are dogs that like it was hypothyroidism that's causing the atherosclerosis and hyperlipidemia. But yeah, they documented atherosclerosis in the arteries around the heart in carotid in golden retrievers, and sporadically see it on postmortem. Sometimes we see mineralization of the aorta on ultrasound, and I don't know what causes that, but I wonder if that's the same thing. Are these the dogs that we should be like concerned about atherosclerosis in?
But when you say mineralization, wouldn't you? I'm thinking like calcium. So is it lipid? Or it's a combination?
It ends up forming plaques, and on ultrasound, they look the same.
Okay. Oh.
Yeah. So when I've looked at, because there's human sonographers whose only job is looking at arteries all day long for atherosclerosis, and they look really similar to what we call a mineralized wall of the aorta, but they're using much more advanced like Doppler and stuff like that. So maybe they can tell the difference between mineralization and fat deposits. Because it causes chronic inflammation, I wouldn't be surprised if there's mineralization there too. Okay. So what do we do if we've got a patient with hypertriglyceridemia?
Find the cause.
Find the cause. Yeah. So you've got a 3-year-old schnauzer who has elevated ALP, but it's only like 270, normal ALT and other liver enzymes, a triglyceride of 25, and is no PUPD and generally clinically well.
I think it's probably too young for hyper A, so I think it would be reasonable to do a trial of a very low fat diet.
Yeah.
And just see if that resolves it.
Perfect. Yeah. So if you're on an exam, you say, I would screen for Cushing's disease, I would screen for hypothyroidism, I would screen for diabetes, like I do full bloods and a urinalysis and blah, blah, blah. Oh, yeah. And protein losing nephropathy as well. But practically, you're going to do a dipstick. And if there's no signs of any of the other diseases, and you've obviously already run bloods because you've got the triglyceride level. And if your T4 is normal, then you're probably going to just manage it to try and reduce those triglycerides. What are the goals of therapy when you're trying to reduce triglycerides?
I think you want it to become closer to normal, but not necessarily normal.
Right. Yeah. The guidelines are under 5. So they used to say a 50% reduction in triglyceride levels is a win, but some of these dogs have triglyceride levels at 30. So it's definitely halving it isn't going to be good enough. The upper range is 1.5 or something. So aiming for under 5 there's a lot of dogs that we're calling hypertriglyceridemic on diagnosis who already meet the treatment criteria, right? Like they're under 5 most of the time. So I only usually do specific treatments if they're over 5, but in all of the dogs that have a hypertriglyceridemia, low-fat diet. There's another component to the diet which will help.
Increase fiber.
Great, excellent. So it just slows down absorption of fat so you don't get the huge postprandial spike, and decreases absorption of it. What other nutraceuticals can we use to reduce fat absorption?
I think niacin.
Good. Yeah. Can't remember how that works. Does anyone know? No, me neither. There's another one.
Oh, omega-3 fatty acids.
Yes. Excellent. Yeah. How does that work?
They increase, this is a bit unfair because I learnt this yesterday with you, but they increase the activity of lipases, of lipoprotein lipase, so they can, your body's more effective at breaking down triglycerides, and they down-regulate the production of some of the lipoprotein carriers in your blood.
Did I say that yesterday? Did you learn that after yesterday?
I learned that because we were talking about it at Taramara, so I went and looked it up yesterday.
I was smarter yesterday. Perfect. Sorry. So if you essentially like hit the intestine with like triglycerides and omega-3 fatty acids, the fatty acids are going to be absorbed preferentially, and they're going to decrease. So say it again, Helen.
They down-regulate your production of some of the carriers of lipoproteins. So you've got less carriers in your, less absorption and less carriers in your blood, and they upregulate the lipoprotein lipase that breaks down your that breaks down the triglycerides. Excellent.
Good. So breaking down the triglycerides means that they can go into the liver and be processed, rather than being deposited in peripheral tissues. The lipoprotein lipases do both. So we've got one that facilitates, we've got a hepatic lipase and we've got a peripheral tissue lipoprotein lipase. So what we're aiming to do is improve the transit of fats and the excretion, the rate at which fats are excreted, rather than have them sitting around in the bloodstream. So it just improves that hepatic absorption of fat and excretion of fats, or utilization of fats. Excellent. Thank you, Helen. Oh, I lost her. I hope I didn't scare her off. Okay, so say you've got a patient with a hypercholesterolemia but a normal triglyceride level. How are we going to manage that one?
And work up the causes for hypercholesterolemia first.
This is much more likely to be an underlying cause unless it's one of those breeds with a hypercholesterolemia. Is a hypercholesterolemia as serious or as detrimental health-wise as a hypertriglyceridemia?
I'm thinking not. But not sure.
Not unless they've got something else, another disease going on that's going to predispose them to complications associated with it. So we just don't get that hyperviscosity with the cholesterol, as much as we do with the lipids. So say we had our schnauzer back and we had it on low fat, low high fiber diet, and the omega-3s at the highest dose we could get away with. And we repeated the blood test and his triglyceride was still 15. What are our options as far as
drugs?
Use drugs. Yeah. Do drugs, kids. Let's say which drugs?
I think they're called fibrates or phenofibrate or something like that.
Yeah.
I'm pronouncing it right.
They're my favorites. Yeah. So there's one that I always used to use, gemfibrozil. That's the one that's kind of spoken about most commonly in the papers and things like that. But actually, this case that we saw yesterday with Helen, the vet was like, "Oh, what do you think about Lipid or something like that?" So it's oh, damn it, I've forgotten. I'll look it up. Where did I put it? Oh yeah, Lipidil, and it's fenofibrate or fenofibrate.
Yeah.
Yeah. And looking at it, so side effects of gemfibrozil is often like nausea, gastrointestinal disturbance, and this one actually looks like it's better tolerated when I actually did a bit of a deep dive yesterday. Side effects are diarrhea and flatulence, but it's self-limiting when you stop the drug. So if you hit them with a kind of recommended dose and they develop unacceptable side effects, stop the drug until the side effects go away, start it again, half the dose, and then work your way up. And usually they tolerate it quite well second time round. So it's a really, does anyone know how they work? Essentially just decrease fatty acid synthesis. And improve catabolism. And that's pretty much all we can do. I mean, there's other statins and things that we can use for hypercholesterolemia, but as I said, we don't typically treat hypercholesterolemia. Does anybody else want to cover anything else with hyperlipidemia?
I was going to ask, what about drug-induced hyperlipidemia like phenobarb?
Oh, good point. Yeah.
Phenobarb like that? Like if it's significant, or do you just do the same kind of principles?
I do the same principles, yeah. I've never seen a hypertriglyceridemia get really, really, really high on phenobarb. Like we've always been able to manage it with diet fish oil concurrently. So phenobarb, obviously they're seizuring dogs. That diet and fish oil are indicated for seizures as well. So it's kind of a nice little bundle of like, here's what I recommend when I give for the phenobarb kind of thing. The other drugs that can do it are estrogens and progesterones. So estrogens probably the main one that we use for incontinence, but I've never seen clinically significant hypertriglyceridemia with estrogens. Yeah, phenobarb's it's the best of the anti-seizure drugs. If it got really high, I'd probably switch them on to imepatone, but it's always my first choice.
Yeah, it works so well.
So well, yeah.
Good.
All right. So what about hypocholesterolemia on your blood tests? Is that even important? Why?
Well, hypocholesterolemia can indicate either hepatic synthetic failure or even in chronic enteropathy. Are the two that I think of usually.
Yeah, good. There's one more, which is kind of a bit obscure and rare. But say we had a 8-year-old Bernese mountain dog who presents with a vague history of 4 weeks of lethargy, weight loss, inappetence, and the only abnormality on blood is a mild anemia and a hypocholesterolemia. Bernese mountain dog.
Oh. I mean, neoplasm is, so do they, histiocytic sarcomas, they do that? Is it?
Yeah. Weird. I don't know why. Well, they don't know why, because I've looked into it a few times, but dogs with histiocytic sarcoma often have a hypocholesterolemia.
Did not know that. Huh.
Yeah. And the reason I mentioned it is not because I like to teach pattern recognition, but also because I love pattern recognition. Sorry, terrible.
Antithesis of medicine.
This is why I don't teach at university. So hemophagocytic syndrome is a form of histiocytic sarcoma. So I don't know if anybody's worked with or seen a case of this. It's quite rare. I think I've only seen like 5 cases on my in my entire career. but essentially it looks exactly like IMHA. It's kind of a bit of a slow burn IMHA because it is IMHA. So essentially what you've got is neoplastic macrophages in the spleen or in the body somewhere, which are just gone rogue and chomping on red cells. So you get spherocytosis, you get you don't get the antibody coating, but we can't really test for that anyway. So you often get a Coombs negative, but you might also get a Coombs positive because those red cells have been damaged. So you might get some immune reactivity around them. So often these dogs are treated as like IMHA, and they respond to the pred because it decreases the histiocytic numbers. And then they kind of relapse and they just have this anemia that just gets slowly and slowly worse. And really the only differentiator that makes me go, I really need to do some invasive testing on this dog is that cholesterol, because everything else looks the same. I think they've got some, yeah, sometimes they've got a platelet count abnormality, but I can't remember if it's high or low. Low would make sense, but anyway, it's just something to keep an eye out for if you've got that like a weird illness and particularly with an anemia.
So would that be any breed, or is it specific to the
any breed? Yeah. So I've actually only seen it in a Bernese Mountain Dog once, and because Bernese tend to get more massy histiocytic sarcomas. So it's the weirdest disease, right? Schnauzers get lung masses, which are histiocytic sarcomas. Bernese Mountain Dogs get like masses in their spleen, focal masses in their spleen. This one that I diagnosed was a greyhound, and its spleen actually looked quite normal, but its hepatic lymph node was like a golf ball. And we did an aspirate of the hepatic lymph node, and it was histiocytic sarcoma. So it just does whatever it wants, because histiocytes live everywhere, right? And there's different genetic predispositions for the histiocytes that are going to become neoplastic, or the histiocytes that live splenic, hepatic lymph node, liver, lung in the different dogs that get it. So the behavior is very unpredictable. Interesting though. All right, let's talk just a little bit about pancreatitis and specifically lipase measurement I'm interested in. So when we do the lipase we get on our normal blood profiles, how specific or sensitive is that for pancreatitis?
To be honest, I don't look at it. I don't really care about that much.
No.
It's very poor.
Yeah. What about in a like postprandial sample? What would we expect to happen to lipase?
Increase.
I think it'll be high.
Yeah, exactly. So we get same reasons why we get a spike in triglycerides, we're going to get a spike in lipase. So if we've got a postprandial sample, if they've had their peanut butter trazodone before they come to a clinic, we're going to get increased lipase, which decreases the sensitivity, but it is a nice question to ask the owners when you've taken the blood, is this a fasted sample, so that you can then correlate that finding. Lipase could come from everywhere, anywhere. And how is it excreted?
Kidneys?
Kidneys, good. Yeah, exactly. So you can get elevations with changes like peripheral tissues, pancreas, like lingual lipase, all of the lipases. But you can also get elevations because it's just too slow to be excreted if you've got renal dysfunction or decreased renal perfusion. And same with amylase as well. So renal disease is a big cause of falsely elevated amylase. So some of those pancreatic markers are just, I think they were like, it's less than the odds of your patient having pancreatitis with an elevated lipase are the same as flipping a coin. So you're just as likely to diagnose it by flipping a coin. So pancreatic specific lipase has been invented, which is very nice. And that's like happened in my career. That's definitely happened in Jeff's career and Bron's too. So, but like, it was really hard to diagnose pancreatitis before, right? How sure are we when we get an elevated CPLI that we've got pancreatitis?
Are you talking quantitative or SNAP? SNAP, I think, is shit because it will be high with any gastric disease or abdominal disease.
Yes, absolutely. So the SNAP cutoffs are lower than the spec cutoff, right? So we get this like gray zone, which means that you have to send off a spec. So it's going to be less specific for pancreatitis, but more you're going to catch all of the pancreatises basically in your positives. Doesn't mean it's pancreatitis if it's positive, but it probably means it's not pancreatitis if it's negative. Probably, sometimes not. What about if we just talk about the spec lipase? If that's high, what are the chances that this is actually pancreatitis?
90%, but I don't know.
Yeah, it actually depends on the population you're applying the test to. So if you do spec pancreatic lipase in 100 normal dogs with no evidence of gastrointestinal disease, which is what a lot of the like tests are done on, like you're going to get some false positives in there, right? So it's going to have a very low sensitivity. Whereas if you apply this test to all dogs with vomiting and diarrhea, you're going to have you're going to pick up 100% of them. So it really does depend. The sensitivity is reported between 33 and 100%. So it's very broad. IDEX is the only test that's actually the methodology that they're running it by is the only one that's actually met the lab test standard criteria. So any other labs manufacturing the CPLI test, they haven't actually they haven't done the proper kind of consistency and regulatory testing. So definitely run it through IDEX to maximize your diagnostic capacity. What other diseases might cause an elevated CPLI where it's not primary pancreatitis is the disease?
Foreign bodies will do it. Liver diseases will do it.
Which one?
Like liver, like anything in the liver will do it.
Yep.
I don't know if renal diseases do it. Like would renal diseases do it?
Yep. So it's a lipase. It's excreted by the kidneys.
Really, so yeah.
Yep. What about sepsis? Or any cause of hypoperfusion, dehydration. Yeah. So pancreas is going to get annoyed. So I think the important sort of take home from this is like we see pancreatitis all the time. The CPLI is elevated. It doesn't mean it's not pancreatitis, but it doesn't mean it's primary pancreatitis. Doesn't mean you can stop looking for a cause. So there might still be a foreign body with secondary dehydration, hypoperfusion. You might have sepsis with secondary hypoperfusion. You might have heartworm and congestion in the pancreas causing elevations there. Probably going to see some other changes, you'd think. Yeah. So that's all I wanted to really cover with a lipase. Anybody else got anything they want to, any questions?
What causes the hyperlipid, I think it's, it must be hypertriglyceridemia in active acute pancreatitis.
It's actually the increased lipase. So the pancreas essentially ruptures and we get massive increases in the amount of lipase in circulation, which breaks down all the fat at once, basically. So we get this really heaps of triglycerides in circulation all at once.
Right.
And that happens both locally, the local mesenteric fat adjacent to the pancreas gets broken down, but a lot of that ends up in circulation as well.
Then it comes first because isn't hyperlipidemia a risk factor for pancreatitis? So then it's like chicken and egg.
Yeah. So hyperlipidemia causes hypoperfusion of the pancreas, which then causes acute pancreatitis. But we also get acute hyperlipidemia secondary to pancreatic inflammation. So that kind of feeds itself. All right, I'm going to actually wrap up a little bit early because I got through everything I wanted to, unless you've got more questions.
I mean, it's not so relevant. In the US, they have this drug now for a while. I don't know how much it's used. Do you know anything about it for the pancreatitis? They're saying that it's reducing the time for hospitalization. It's a
I did read about this.
Razipilib or something, Panaquil, it's the trade
Still
name.
my
And it's,
boyfriend drug? Is it that neutrophil anti-neutrofiltration drug?
yeah.
Yeah, I heard about it.
Do you have any sort of?
No, I completely forgot about it. I assumed it wasn't available in Australia.
It's not like that's the thing, but
Annoying.
like I don't know if it's something that's coming down. Do you have any idea?
If it works, it'll come, right? We'll let the Americans do all the trials and then take it.
Get the verified version.
Yeah, exactly. Yeah, watch this space. I reckon we'll get to a pancreatitis chapter and we'll do it in a lot more detail and we'll go through it then, I reckon. And hopefully it'll be out by then. Someone will market it heavily and tell us about it.
Hopefully. I would like to try that because it's like some people are saying it's good, so I would like to, but we don't have it here.
It would be nice to have something to treat them with.
Yeah.
It's annoying to have to say, we're just going to ride this out. All right, I'm just going to push stop.